Okay, so now we're going to talk about wounds that are caused by external mechanical forces. And we're going to differentiate between partial thickness or superficial wounds, which are caused by top-down injury, and deep or full thickness wounds that are caused by bottom-up. So we're going to start with top-down. These are lesions that are frequently classified as partial thickness, meaning you've lost part but not all of the skin layers themselves. So you've lost the epidermis, you may have lost part of the dermis. Now, how these wounds present, first of all, of course, just the depth is very significant. There's going to be either no measurable depth or they're going to be typically 1 millimeter, less than 2 millimeters, less than 0.2 centimeters in depth. Then the second thing you go by is, what does the wound base look like? So sometimes you have a bright red wound base like you see on top. That's what you typically see when the top layers of the epidermis are gone and you're looking at that bottom layer of reproductive epidermis that's bright red all the way across. But sometimes you'll have a wound that extends into the dermis. And when the wound extends into the dermis, remember the dermis is made primarily of collagen, which is a very pale tissue layer. And so these wounds look white or very pale pink, but scattered throughout the wound bed you'll have distinct little red epithelial islets. Because remember, every place you have a hair follicle, that hair follicle is lined with that reproductive layer of epidermis. So sometimes it's bright red, sometimes it's pale with distinct red epithelial islets. Sometimes you have a skin flap. We'll talk about that in just a minute when you have a skin tear. And sometimes it'll look salmon colored. So here you see a wound that looks salmon colored. Again, very, very superficial, minimal depth. The reason it looks salmon colored is because the hair follicles are so close together that instead of presenting as a pale base with distinct red epithelial islets, instead it looks salmon colored. Okay, so those are the characteristics, very superficial, typically painful if they have intact sensation, because when you take off the top layer of skin, as you know from experience, you expose a lot of nerve endings and it's very sensitive. So minimal depth, no necrotic tissue, no slough, no eschar, no undermining, no tunneling, and the wound base is either going to be bright red, pale with red epithelial islets, or have a salmon colored appearance. So let's talk about the types of injuries that would present as partial thickness wounds. And the first is a friction injury, friction damage. When you think of friction damage, you want to think of sanding force. You think about if you're refinishing a piece of furniture or you're going to paint a wall. Many times the first thing you do is take off the old finish. And you may use a combination of sandpaper and some kind of removal agent. But when you're using the sandpaper, what are you doing? You're mechanically removing one layer at a time from the top down. The same thing can happen to our patients, especially when they have very fragile skin or when their skin is overhydrated and therefore more vulnerable, and they're restless and moving around in bed, and so they're constantly scrubbing the skin against the underlying linen. Or we have to put them in soft restraints and they're restless and they're getting this kind of chafing force against the skin. You've had that happen to you when you've had something that was too tight and it was rubbing against your skin. You've had shoes that were too tight and every time you took a step it rubbed against your skin. What's the first thing that happens? Your skin becomes reddened and sensitive because you're getting damage. You're taking off the top layer of the skin cells. You're causing damage to the underlying cells. That triggers that inflammatory response and sensitivity. If you don't interrupt the source of injury, if you're forced to keep walking in those shoes because your car is a long way away, what ends up happening is you end up with an open blister where you've got exposed underlying dermis, and it's very, very sensitive. So that's the pathology of friction damage. It's simply mechanical force that abrades the skin one layer at a time. Now, in our clinical examples on top, you see a patient, we talked about him earlier, very, very fragile skin, very restless, moving around in bed, scrubbing skin off, taking off little patches of skin. He had also had a yeast rash, which made his skin even more vulnerable. In the slide on bottom, you see a patient who has incontinence-associated dermatitis, meaning his skin was very macerated, very overhydrated. And as we said in the previous presentation, when there was aggressive cleansing and aggressive removal of the zinc oxide, they mechanically abraded the skin. So you think of friction, mechanical abrasion of the skin, more likely in patients with very thin, very fragile skin, and also in patients with overhydrated, macerated skin. How do we prevent friction damage? Well, first of all, keep the skin as healthy as possible. So prevent overhydration, prevent that maceration. Teach everyone the importance of gentle skin care. When they see people with very fragile skin, when they see patients with very macerated skin, they want to recognize, you want your CNAs to recognize that skin is extremely vulnerable. They need to use very, very gentle technique in cleansing that skin. We'll talk in a later session about the value of support surfaces that have a low friction, low shear surface. What happens when you put a patient on a support surface that has Gore-Tex or a nylon cover is that they glide against that surface, and that prevents a lot of the friction damage. Some of your support surfaces also have low volume airflow, which keeps the skin drier. Skin that's drier glides more easily. So if you have a low friction surface and low volume airflow, you go a long way toward protecting that patient against friction damage. And then finally, think about using protective dressings. So in the past, we've sometimes done something as simple as put a transparent adhesive dressing or a thin hydrocolloid dressing over an elbow or over a heel when a patient was very restless, or around a wrist underneath soft restraints to provide an extra layer of protection. A very common approach now that is evidence-based is to use your silicone adhesive-based foam dressings to the sacrococcygeal area in patients who are high risk for pressure ulcer formation. Does not protect against pressure, does help protect against friction and overhydration of the skin. So helps protect against that superficial damage that then can progress to deeper damage. Now we're going to talk about skin tears. Skin tears are very common. We mentioned this earlier, both in your neonates and in the elderly, so at both ends of the life cycle. And that's because in the neonate and the newborn, that interlocking configuration has not yet developed, and in the elderly it's been lost. So the skin layers move independently against each other, and it's very easy to create a flap of epidermis that's separated from the dermis. Occasionally you'll get an epidermal dermal flap that separates from the subcu, but that's much less common. Now we want to focus again on prevention. Always we want to focus on prevention. How can we prevent skin tears? Well, you can use protective sleeves. You can do something as simple as stockinette that creates a protective sleeve. You can wrap the arms in a very soft gauze like Cling or Conform. You can take knee socks and cut off the toes and create a matching set of arm warmers. Anything that gives mechanical protection and alerts everyone that that patient's high risk for skin tears. We mentioned that earlier. Now, once a skin tear occurs, you have to set up protocols for management. You want to keep management protocol is very, very simple. You want to constantly reinforce to your staff the goals in skin tear management. Remember, you're always trying to manage exudate. You're always trying to keep the skin or the wound surface itself just moist, and critical to prevent further trauma. Now, back when the only moisture retentive dressing we had was transparent adhesive dressings like Opsite and Tegaderm, we sometimes use those over skin tears. But they're certainly not optimal because they don't absorb drainage. They do maintain a moist surface, but they actually allow further maceration of the skin because of the lack of absorptive capacity. And they have very aggressive adhesives, so when you remove them, even if you're very careful, you're very likely to take off another layer of skin and create another lesion. So when you're managing skin tears, your goal always is to select a dressing that absorbs drainage, maintains a moist surface, prevents trauma with removal. One of the simplest options, and this involves products that are almost always available, is to take something like Adapted or Vaseline gauze or Zeroform gauze or Viscopaste. So your non-adherent contact layer, place that over the skin tear and then wrap with a soft gauze. The Adapted or Zeroform or Vaseline gauze or whatever will keep the surface moist. It will allow any drainage to pass through for absorption by the outer layer of gauze, and it will provide a traumatic removal. Now, some of you are in settings where you have silicone-based adhesive foam dressings. Those would be perfect because you can put them down knowing that the foam will absorb the moisture, the exudate. It will keep the surface moist. And because it's a silicone adhesive, it will cause no trauma with removal. So if you have access to that, that's great. The bottom line is you always go back to your principles, and when we start working with dressings and playing with dressings, we'll come back to that. That you always go back to your principles, and you can work with a wide range of products to obtain the desired results to get your wounds to heal. Now, I did want to differentiate between management of a skin tear that has an intact flap and management of a skin tear with no flap. So let's go back. Here you have a skin tear with a flap. Now this flap actually is necrotic, so we're going to have to trim that flap away, and it will become a skin tear with just an open wound. But what if that flap was viable? Let's assume for a moment that this is a viable flap and that this skin tear has just occurred. What you're going to do is you're going to flush the wound, you're going to roll that flap back into place, you're going to secure the flap with steri strips, and then you'll add your dressing. So if you have a viable flap, use your flap as part of your dressing. It's not going to stick back down, the skin won't stick back down, it's not like a skin graft, but it's the best dressing you can find because it's the skin. So viable flap, roll it back into place, secure it, dress on top. If the flap is non-viable, or if it's if the flap has been removed, then you end up with a lesion that looks like this. You're going to focus on exudate management, maintaining a moist surface, preventing further trauma. When you look at setting up a protocol for your staff, the bottom line is that they can use the same dressing whether or not they have an intact flap. So what you instruct your staff to do is assess the wound. If they have an intact flap, roll it back into place and secure it. If the flap is necrotic, trim it away. And then select a dressing that will handle any exudate, that will keep any exposed wound surface moist, and that will provide a traumatic removal. So you could use Vaseline gauze and wrap gauze on an open wound like this, but it would also be appropriate if you had a wound that was partially covered by the flap with an exposed periphery. So any of the dressings that we've talked about would be appropriate both for a skin tear where part of the flap was retained, all of the flap was retained, and for a skin tear where none of the flap was retained. And that's how you want to set it up. You want to set it up so that it's so simple that it's very easy for your staff to follow through, that they don't have to think, oh, if it looks like this, do this, and if it looks like that, do that. No. Intact flap, roll it back into place. Necrotic flap, trim it away. And then here's our dressing protocol. Now we're going to talk about moisture lesions. There's been a major push in the last few years to sort out and to separate and differentiate between moisture-related lesions and pressure lesions. We've talked in earlier sessions about the fact that for many years we dumped all of these together. We really made no attempt to clearly differentiate. We've also talked about why it's important to accurately determine the etiology of a wound and to separate out moisture-based lesions from pressure-based lesions. Now, there's actually two major types of moisture-based lesions that are likely to occur on the trunk: IAD and ITD. IAD is incontinence-associated dermatitis, and what you want to think about when you are considering IAD is that the source of the moisture is external. It's prolonged or repetitive exposure to urine, stool, or both. Typically, that results in overhydration of the skin, very vulnerable skin. If you have liquid stool, it can result in enzymatic damage to the skin. If that overhydrated, extremely vulnerable skin is then exposed to minor trauma, you can end up with major skin loss. So incontinence-associated dermatitis, the source of the moisture is external, and the way you protect a patient from IAD, from stool and urine, is you put a moisture barrier between the skin and the urine, between the skin and the stool. And we'll cover in more detail the various types of moisture barriers that are available, but right now I just want you to focus on the fact that when you're dealing with a patient with incontinence-associated dermatitis, your goal is to protect the skin from the stool, protect the skin from the urine. Come back to that in just a minute. Intertriginous dermatitis, ITD, is caused by an internal moisture source. So that's what you get when you have a patient who's diaphoretic. A diaphoretic patient is going to trap perspiration and body folds. And then very, very minor trauma, as we have said, can cause a spontaneous crack in that skin. ITD always presents as a linear break, a fissure, at the base of a skin fold. To prevent ITD, your whole goal is to wick moisture away. There's a number of ways to do this. There are commercial products that you can use to wick moisture away. There are also non-commercial products like ABD pads, hairy pads, soft towels like hand towels, knee socks, anything that will separate the skin folds and absorb or wick the moisture away. So to prevent IAD, you're thinking moisture barriers. To prevent ITD, you're thinking wick the moisture away. Now, on your handout, whether you're looking in your hard copy or whether you're looking online, it goes through the different types of moisture barriers that are available, and I just wanted to mention those briefly. We'll come back to this in later discussions. But it basically comes down to 4 types of moisture barriers. You've got your petrolatum-based products, which are basically Vaseline-based products. Vaseline-based products have some advantages in that they're very easy to apply, very easy to remove, don't cause trauma to the skin with application or removal. And they do provide effective protection in general against urine and against solid stool. Not very good protection against liquid stool. one potential problem with your petroleum-based or petrolatum-based products is that they can transfer to the underpad, and they can actually waterproof the underpad and trap the urine or the stool between the underpad and the skin. They actually did a study that demonstrated that very effectively. So you have to be very aware of that possibility. Obviously, that's not our goal, to protect the underpad. The other problem, of course, is that if you already have damaged skin, petrolatum-based products don't adhere very well. They tend to slide off. So what we're seeing in clinical practice is that people are using petrolatum products less. When you see petrolatum, it's usually a product where there's a combination of petrolatum and zinc oxide, in which case the petrolatum is used to make the product easier to apply and easier to remove. The zinc oxide is what gives you the higher level protection against stool and urine. If you come down to the next one on your handout, it's dimethicone. Now, dimethicone is very widely used, both as a moisturizer and as a moisture barrier. Has several advantages. First of all, very easy to apply. Actually penetrates into the stratum corneum. So it fills the gaps between the skin cells, helps maintain that intact barrier function that we discussed in an earlier class, but also creates a film that provides a degree of protection against urine, against solid stool. One advantage of dimethicone, in addition to the fact that it's easy to apply, does not have to be removed, is the fact that it's non-occlusive. So it allows moisture vapor to pass through for evaporation. That can be a real advantage if you have a patient who needs a moisturizer to keep their skin supple, but the patient's diaphoretic, and you don't want to trap moisture against the skin. So you would prefer dimethicone in that situation because it allows the moisture vapor to pass through while keeping the skin soft and supple, maintaining an intact barrier, and providing protection against urine and solid stool. Zinc oxide, I think we all know zinc oxide. We know that the advantage is it provides very high level protection against liquid stool. It can be used on damaged skin to provide an occlusive, thick covering. The disadvantage is that it's very difficult to remove, and if people are aggressive with removal of the zinc oxide, they can further damage the skin. So we have to teach people very gentle removal. Use a cotton ball that's moistened in either warm water or in a perineal cleanser or in mineral oil to very gently remove the zinc oxide. Another thing that is done in some agencies, and I'll show you this when you're on site, is sometimes they'll do a thick coat of the zinc oxide and then take a little square of a plastic film like saran wrap press and seal and use the saran wrap press and seal as a cover dressing, which keeps the zinc oxide from transferring to the underpad, prevents removal when the patient's moving up and down in bed, prevents contamination when they have another incontinent episode, and makes cleanup very easy. So I'll show you that when you're on site. But I want you to notice the fourth type of moisture barrier that we sometimes don't think about because we're so locked into thinking about ointment type products. And that is your copolymer film products. Now the one that has been studied most extensively is Cavalon by 3M. In one study in a long-term care facility, they actually compared 4 different protocols for preventing incontinence-associated dermatitis. One was zinc oxide-based, one was petrolatum-based, one was a combination product, and one was the Cavalon spray applied 3 times weekly. And what they found was all 4 protocols were very effective and protected the patients against breakdown. So clinically, pretty much comparable across the board. But they also found that the Cavalon was somewhat less expensive because it didn't have to be applied as frequently. Only had to be applied 3 times a week, allowed the staff to monitor skin status. So just be aware of that as another alternative. Okay, so we have said that partial thickness breakdown starts at the top and comes down. It's characterized by very superficial wounds, maximum depth 1 to 2 millimeters or 0.1 to 0.2 centimeters, with a wound base that is viable, either bright red, pale with distinct red islets, or kind of salmon colored in appearance. No slough, no eschar, no tunneling, no undermining. We've said that pathologic processes leading to superficial breakdown involve top-down damage, mechanical damage, and the two major sources of damage to the skin, starting at the top and coming down, are abrasive forces, friction, which people are exposed to as they move around in bed. They're exposed to when we clean them up. And moisture, overhydration. Moisture can come from an external source like urine, liquid stool. Moisture can also come from an internal source, diaphoresis. Now we're going to switch gears and we're going to talk about full thickness wounds that are bottom-up injuries. They start typically at the muscle-bone interface and gradually rise toward the skin. These wounds, by definition, involve total loss of the skin layer, so total loss of the epidermis and the dermis. You've got extension into the fat and frequently, most of the time, extension into the muscle. The characteristics, as you see here, you have depth, so there's clear-cut crater formation. Full thickness wounds are going to be greater than 2 centimeters, greater than 0.2 centimeters in depth, and frequently much greater in depth. Very common to see evidence of tissue necrosis because this is an ischemic pathology. So very common to see slough or eschar or purple discoloration of the tissue under intact skin, which you see with suspected deep tissue injury, suggests ischemic pathology. Also, it's very common to see undermining and tunneling. And that's because many times you have shear force as well as pressure. So looking here, the causative factors, of course, are pressure and shear. If you have a pressure ulcer alone, no shear force involved, it's going to present like you see on top. Pressure ulcer alone will essentially mirror the shape of the underlying bony prominence, so it's going to be basically round or slightly oval. Typically extends to the muscle, as you see here, and again, very common to have necrotic tissue. In the slide on top, you see eschar. If you have a combination of pressure and shear, very common to see elongation of the wound and to see extensive undermining. Why? Because shear involves tissue layers moving against each other. Shear force causes disruption or kinking of blood vessels, and when you disrupt or kink a blood vessel, you're going to get ischemic damage to the tissue supplied by that vessel. So shear force isn't a very regular, predictable force. It can go in any direction depending on which blood vessels have been disrupted or angulated. Now, we talked earlier about why it is that pressure shear injuries start deep and come to the surface. So just as a reminder, when all tissue layers are compressed and you reduce blood flow to all of those soft tissue layers, the layer that is going to get into trouble first is the muscle layer, because that's the layer with the highest metabolic rate. It's also the layer that's immediately adjacent to the bone, so it gets the greatest impact of the bone. This has been supported by studies where they have anesthetized laboratory animals, exposed them to prolonged periods of pressure, done a full thickness biopsy, looked at the tissue under the microscope. The first layer to develop damage, the muscle layer. Microscopic ulcerations show up there before they show up anywhere else. Now, when you look at the pathologic processes involved in pressure ulcer development, there's basically three things that work together. First of all, prolonged, sustained pressure, or very high level pressure, but for our patients it's almost always the prolonged pressure because our patients really aren't exposed to extremely high pressure. The second thing, some of our patients are exposed to shear force, not all, but many are exposed to shear force because most of our patients require head of bed elevation, and that's going to introduce shear force. We talked about that. And then finally, compromised tissue tolerance. So we certainly know that if we have a patient who's very thin and has no subcu tissue to evenly distribute their weight, we know they're higher risk at baseline because they're going to get higher peak pressures and they're going to be less able to distribute the weight effectively, so they're going to get into ischemic changes at an earlier point. What about a patient who is on vasopressors? So their systolic pressure is low, maybe in the 60s or 70s, plus the vasopressors cause cutaneous circulatory shutdown, so the blood vessels to the skin layers are constricted. Obviously that patient's much higher risk for pressure ulcer development. What about a patient who's febrile? Yes, higher risk because the tissues are hypermetabolic. They're going to use oxygen at a much faster rate, and the patient's going to become oxygen hungry. Their tissues will become hypoxic at an earlier point. Now let's talk about what we know about perfusion of the skin and soft tissues. So we know that it's this big highway system where you start out with very large arteries and smaller arteries, then arterioles, and eventually the capillary bed. And pressure ulcers occur because of compression of the capillary bed. Capillaries, we know, are thin-walled. We know that the capillary bed is a low-pressure system. So it's easy to understand why sitting or lying right over a bony prominence would compress the tissues and compress the capillary beds within the tissues. Now, a question that has been asked, and a very relevant question, is how much external force is required to collapse the capillary bed? And you would think in 2012 we could give a very definitive answer to that question, but we can't. Here's what we do know. We know that if you have very even distribution of the pressure across a wide body area, that in itself is protective, because in that case there's no place for the blood to go. If you've got evenly distributed pressure against all of the capillary beds on the posterior surface of the body, the blood itself keeps those capillary beds open. So we know that it's peak pressure, not evenly distributed pressure, that is an issue. Okay, so how much peak pressure does it take to collapse the capillary, to shut down the capillary bed over a bony prominence? Well, there were some studies done way back before anesthesia by a researcher named Landis. And what he did was he took little pipettes and he drove them under the nail beds of his poor subjects and connected them to manometers to see what the pressure was in the capillary beds. Now, what he found was that on the arterial side of the capillary bed, it was about 28 to 32 millimeters of mercury. On the venous side, about 25 to 28. And based on that, a lot of people say, oh, well, the pressure within the capillary bed is 32 millimeters of mercury, and as long as you keep external pressures lower than that point, you'll maintain blood flow. But of course, we know that blood pressure is extremely variable. Systolic blood pressure varies from person to person, from site to site from time to time. Capillary pressure is downstream of the big vessels where we measure systolic pressure. So certainly a patient who has a systolic pressure of 135 is going to have higher capillary pressures than a patient whose systolic pressure is 70. So we know that capillary pressures are variable. They're going to vary from patient to patient. They're going to vary from site to site. They're going to vary from time to time. Our current data suggests that the functional capillary pressures for most of our patients is probably more in the range of high teens to low 20s as opposed to low 30s. So bottom line, we don't know exactly, but we know that capillary beds are low pressure and that probably the pressure in the capillary beds is somewhere around 17 to 20, something like that. Okay, what else do we know? We know that if you get peak pressure that's higher than the pressure within the capillary bed, yes, you will collapse the capillary at that point. You will shunt the blood right and left or proximal and distal, but you'll close off the capillary bed over that compressed area. Now, what happens when you close off the capillary bed? Well, initially nothing happens. It turns out that the tissues do not require constant blood flow. They require intermittent blood flow. That's why you can go and sit on a concrete wall for a little while or on a hard bleacher for a little while. You can lie on an x-ray table for a little while because the tissues require intermittent blood flow. The other thing that we know is that we are all equipped with a built-in pressure ulcer prevention system. And that pressure ulcer prevention system involves sensory awareness and the ability to move. So when you sit down on bleachers or on a hard surface, if you went and checked with your tissues and you said, hey, are you okay with this? I know I'm cutting off your blood supply. Is that a problem for you? Your tissues would say, don't worry about it. I'll let you know if I get oxygen hungry. And they do, right? Because when the tissues start to get oxygen hungry, you feel uncomfortable. And you shift, usually without even thinking about it. So it's like your tissues send a very gentle message at first that says, please shift your buns. And you do. But if you fail to respond to that initial message, they'll send a stronger message. I said move it. And they'll keep on with the message getting more and more intense until you move. You've probably all had the experience of rolling over on your arm at night and you wake up because your arm's shrieking at you, get off of me. And you hold it out to see what you can do, and you can't do anything, of course, because the nerves and the muscles are hypoxic. The point is that ischemia, that hypoxia was uncomfortable enough to wake you up. I've never had a patient with one arm because they didn't wake up. So ischemia will wake you up, it will alert you, it will make you move as long as you have the sensory function to recognize those ischemic signals and you have the ability to move. Our high-risk patients are patients who have either lost sensory or they've lost mobility. So there are heavily sedated patients. There are patients with advanced dementia who can't respond appropriately. There are cord-injured patients or patients with profound neurologic damage. There are paralyzed patients. Those are the patients we have to protect. The other patients will go a long way toward protecting themselves. Okay, so we talked about that. We talked about all of these things. Should have let the slides, obviously. Okay, so looking specifically at the impact of prolonged pressure, you're going to get eventual reduction in blood flow. it's not that you get eventual reduction. You get early reduction in blood flow, you get eventual ischemic changes. So let's go back and let's look at what happens if you have a patient who's resting on an x-ray table versus a patient who's on a, say, pressure-reducing mattress. So let's look at our patient on the x-ray table. Okay, x-ray table is not at all conformable, so all of that patient's weight will be supported by bony prominences. That patient's going to get peak pressure, and immediately there will be shifts in blood flow. So blood will shift away from the areas of peak pressure into the surrounding blood vessels. And pretty rapidly, the tissues over the bony prominences will become ischemic. That patient, if he or she has intact sensation, will become uncomfortable very, very quickly. If that patient does not have sensory awareness and we leave that patient on that rigid surface for any length of time, they're almost definitely going to develop a pressure ulcer. But we're careful not to do that. So now let's look at the much more common scenario where we have a patient, the patient's on a hospital bed. That hospital bed is equipped with a pressure redistribution mattress. So yes, there's some degree of blood vessel compression, but it's not complete. It's partially compressed. Okay, well, I want you to think about a 4-lane highway where you have partial interference to traffic. Maybe there's an accident in the far right-hand lane, and the accident and the emergency vehicles are occupying the 2 right-hand lanes. The 3rd lane is pretty much involved with rubbernecking to see what's going on. So you have 1 lane that's passing through pretty normally, 1 lane where cars are getting through very slowly, and 2 lanes where nothing's going through at all. Marked reduction in traffic flow. That's what happens when you have partial compression of the blood vessels. So yes, we have the patient on a pressure-reducing surface. There's partial, not complete, compression of the vessels. But there's diminished blood flow to the tissues. Now, do those tissues become immediately ischemic, immediately hypoxic? No. But what if I leave that patient there for many hours? And there's reduced blood flow, reduced blood flow, reduced blood flow. Will the tissues exhaust the supply of oxygen? Will they become progressively hypoxic because they're not getting enough oxygen on a moment-to-moment basis? Yes. So if you put patients on rigid surfaces, they develop ischemia early. If you put them on more conformable surfaces, they develop ischemia eventually. When they develop ischemia, then there are going to be changes in the cells and the soft tissues that result eventually in tissue death. And we've already talked about the inverse relationship between the intensity of the pressure, the level of interference, the blood flow, and how long the tissues can survive that interference. So I'm going to go back because I don't think I really summarized what I wanted to here. And that is, what are the implications? The implications are, it helps tremendously when you put a patient on a conformable pressure-reducing surface, because then you limit the degree of vessel compression, you maintain some degree of blood flow, and you delay the development of tissue ischemia. But that's not enough. The other thing we have to remember is that time will catch up with us, and so we also have to put that patient on a repositioning program, so that every 2 to 4 hours we come in and we move that patient, we take them off that surface, we restore full blood flow, and we reverse any oxygen deficit. Okay, so that gets back to our 2 strategies for preventing pressure ulcer formation. Routine repositioning, and of course in the past we've said Q2 hours in the bed. I want you to be thinking more like Q2 to 4 hours, because I'm thinking most of you have good quality pressure redistribution mattresses on your beds, and every hour in the chair. And absolutely critical to make sure that you're using appropriate pressure redistribution mattresses. so that you don't get those peak pressures. You get even distribution of the pressure. Any compression is partial, not complete, so that it buys you time and delays the development of tissue ischemia. Now, shear force we talked about before when we were talking about preventive care. Shear force occurs when we slide down in bed, slide down in a chair. The skin will become adherent to whatever surface, so it's going to tend to stick to sheets in the underlying mattress with a standard surface. Deep tissue layers will always respond to gravity. If the skin remains stationary, the deep tissue layers move. What happens is the fat moves in between, and the blood vessels that are moving through the fat get kinked or torn, and that's when we get shear force. Shear force is a significant contributing factor to deep tissue breakdown, to pressure ulcer development. So we want to maintain a major focus on shear prevention. And I know we talked about this before, but I'll mention it again briefly. The value of low shear, low friction surfaces. When you put a patient on a low shear, low friction surface, what you do is you eliminate that drag. So instead of the skin remaining stationary, the skin moves with the underlying tissue layers. So you don't get this, because you get this. They slide, but there's no drag. If there's no shear, there's no kinking of blood vessels. If all the tissue layers move together, then you maintain perfusion. You do not cause disruption or angulation of the blood vessels. So that's why most of your high-level support surfaces incorporate a low shear, low friction cover to prevent shear force or to significantly reduce shear force. The other things, of course, we already know, use lift sheets to move patients up in bed. If we have to elevate the head of the bed, consider partial elevation of the gatch so that we offset that sliding force, or consider elevating the foot area of the bed. When patients are up in the chair, we want to make sure that they're on a cushion that's elevated in the front so that it stabilizes them, or there are pommel cushions that will stabilize them. We want to make sure that they're wearing shoes, like athletic shoes, that will grip the floor, because we don't want them to slide down in the chair. We want them to be stationary in the chair. So everything we can do to prevent shear force goes a long way to maintaining tissue integrity. Back to the protective dressings. The protective dressings incorporate a very slick outer layer. So when you put those silicone adhesive foam protective dressings over the sacrococcygeal area, that very slick outer layer stops some of that drag and helps all layers move together. Now, we talked about compromised tissue tolerance, patients who are more vulnerable at baseline. We talked about patients who are very thin. Talked about patients who are febrile. Talked about patients who are hypotensive and on pressors. What about your patient who comes in with advanced coronary artery disease? They're admitted for a coronary artery bypass grafting. Look at how we frequently manage those patients. So we're so concerned about cardiac function, and we should be, and pulmonary function, and we should be. But many times we're not thinking about protecting their heels. And if you have advanced coronary artery disease, you also have peripheral arterial disease, which means at baseline, you're not getting as much blood flow to the tissues in the lower extremity. So then if I bring you back from surgery and I leave you with your heels on the bed, oh, and of course I have you in TED stockings and SCD wraps, and 2 days later I think, I should check their heels, what are your heels likely to look like? Foggy, purple, a pressure ulcer in evolution. So critical for us to realize patients who come in with coronary artery disease, they also have peripheral arterial disease. We have to protect their the heels. Very high risk for heel ulcers. What can we do about your very high-risk patients? Is there something magic we can do? No, except recognize that if I have someone who's very thin, if I have someone who's febrile, if I have someone who's hypotensive, if I have someone who has coronary artery disease, I need to realize they're higher risk. I need to ramp up my prevention protocol. I need to monitor them extremely carefully because it's going to be a fight to keep them from developing a pressure ulcer, but a fight that we can probably win for most of our patients. So the last thing I wanted to cover in this section is the process of pressure ulcer development, what goes on. So what you see here, on the top slide, you see a male sitting naked on plexiglass while someone crawls underneath and makes slides of his buns. And what you want to notice there, what they're trying to show us, is what happens when someone's on a rigid surface. And because the surface is totally rigid, you get immediate and total ischemia over the bony prominences. You see total power, which tells you what? Those blood vessels have been totally compressed. There is no blood flow to that area because you have very high peak pressures. And the blood that should be flowing through these capillary beds has been diverted to the surrounding tissue. So obviously this patient is going to develop early ischemia over the ischial tuberosities. Now I want you to also notice the surrounding erythema. That's because those hypoxic tissues are sending out a constant SOS to the surrounding vessels. Constant I need oxygen message. And so all the vessels are dilated trying to deliver oxygen and blood to that compromised, compressed area. But of course, the blood can't get through because the vessels are shut down. However, that explains what we see when we relieve the pressure. Obviously a different person, but this person's been turned off of the sacrococcygeal area. And what do you see? You see that classic discoloration. Erythema and fair skin, darkening, and deeply pigmented skin. If you touch the skin, it frequently feels warm. Is this a stage 1 pressure ulcer? No. This is a normal response. This is reactive hyperemia. I call it tissue CPR in progress because what's happening? You have all of these tissues that are oxygen hungry, that built up an oxygen deficit. Now blood's rushing into that area to supply oxygen and nutrients, pick up carbon dioxide. As soon as those tissues get their oxygen needs met, they'll stop sending out SOS signals and the surrounding vessels will go back to normal size. And once they go back to normal size, that warm dark spot goes away. So reactive hyperemia, a normal response, blood rushes into all the dilated vessels to meet oxygen needs, but a short-lived response. And blanchable. Short-term blanchable erythema. Normal, not pathologic. But, let's go to the next slide. Both of these represent pathology. On the top, you have stage 1, and on the bottom, you have suspected deep tissue injury. Now, what's going on here? Well, when you see prolonged, persistent erythema, what you have is not a normal response, but an inflammatory response. You have persistent dilatation of the blood vessels. And the reason you get persistent dilatation of the blood vessels is because you have sustained microscopic trauma at the muscle layer. Trauma triggers the whole wound healing pathway, and it kicks off with vasodilation to increase the blood flow, increase the oxygen delivered to the tissues. So prolonged erythema, non-blanchable erythema, both indicative of some degree of underlying tissue damage, a pathologic response, a warning. It tells you something's happened in the underlying tissue. Right now, it's not terrible. It's microscopic. We think we can get it healed if you keep all the pressure off, if you avoid any shear force. So your goal when you see a stage 1, the reason you want to make it a big deal for your staff is we've got to get in there, we've got to be very aggressive, we've got to keep the patient totally off of that area until all of the erythema has resolved. As long as you have erythema, it's a warning sign that repair is underway. Now, what you see on bottom is, of course, much more significant. This is suspected deep tissue injury. This is where you have deep bruising under intact skin. We're not totally sure what causes that deep purple discoloration. One theory is that it's necrosis of the soft tissue that's being reflected at skin level as this deep purple discoloration. Another theory is that you've gotten disruption of blood vessels and blood's leaked out into the tissues. But what we know from multiple studies is that the expected outcome for this picture and this picture are pretty different. If you have persistent or non-blanchable erythema and you do everything right and you keep the patient off of that area and you avoid massage to that area, almost always it will resolve without ever turning into an open wound. In contrast, if you have an area that looks like this, even if you do everything right, you keep the patient off the area, you prevent any further trauma, any further damage, it still may progress to a full thickness wound and frequently does. Now there's studies going on to see if you can reverse SDTI, suspected deep tissue injury. In some settings they've been working with ultrasound therapy, mist therapy, to see if they can dissolve any tiny little emboli, open up blood vessels, reverse ischemia, and minimize the tissue damage associated with SDTI. Do we have enough data to make that standard of care? No. I'm just telling you that people are working and are conducting research to see, can SDTI lesions be reversed? Our early data indicates that some can and some cannot. Makes sense, because the whole problem with a suspected deep tissue injury is that you're trying to see through intact skin to see how severe the underlying damage is. Of course, we can't see. So it makes sense that probably some of the patients with SDTI lesions have less severe pathology, others have more severe pathology. Some may respond to restorative therapies and others may not. That's research that's ongoing. But right now, I want you to be very clear about the difference between a stage 1 and an SDTI. And I particularly want you to be clear about the difference in prognosis. Stage 1, totally expected to resolve with appropriate management. And in fact, deterioration from a stage 1 to a full thickness wound would raise major concerns about management. In contrast, progression from an SDTI to a stage 3 or 4 would not raise concerns about management, because at this point in time, it's essentially the expected progression. So we'll be talking more about that when we talk about staging. Now the last thing I want to go over, last two things really, not so much on the slide, but on your, either in your hard copy book or in looking at your core content on Blackboard. You have a little section under the sequence of events leading to pressure ulcer development, where it goes specifically through the pathologic process or the pathologic response to prolonged ischemia. I just wanted you to realize everything occurs at the cellular level. When there's a prolonged reduction in the volume of blood flow and the volume of oxygen, there's a shift from aerobic to anaerobic metabolism. That has major implications and causes major derangements in cellular metabolism. and the end result is leaky edematous cells that eventually will die if that is not reversed. An unknown aspect of pressure ulcer development and another area of ongoing research is, does reperfusion injury play a role? Now we know that reperfusion injury can play a role in other ischemic processes, so that first you get the damage caused by the ischemia itself. The ischemia damages the endothelium, you restore blood flow, now you get shedding of those endothelial cells that can create additional little emboli and cause recurrent ischemia. How much of a role reperfusion injury plays in pressure ulcer development, we really don't know. So it's 2012. We know so much more about pressure ulcer development than we did 20 years ago. We have a lot left to learn. We still don't know all of the pathologic mechanisms involved. We don't know exactly what's going on with SCTI. We don't know exactly which wounds can be reversed and which ones cannot, but we're learning. Okay, I think those were the main things we wanted to cover there, so you can shut your computer down, and we will go on a little later and talk about prevention protocols and support surfaces. Thanks.